Thank you for choosing to join us on Thanksgiving here in the United States. Thanksgiving is, as is true of many things in the United States, politically very complicated. But practically speaking, two things. One, I think it's actually very telling that and timely that the most recent two. We have two episodes that came out this week, but one of them is a deeper reflection on Native Americans, and an episode that I actually am halfway through and haven't finished yet, but highly, highly recommend it already. But practically speaking, for those who celebrate Thanksgiving today, it's a time where people get together with their families and have tend to wear loose clothing to fit the excessive amount of food intake that we're privileged to have, and a time where people are grateful for express their gratitude for the people they care about. And Charmaine and I were texting, reflecting on whether we should have a VMR today, and I think it really is. It was a very easy decision to hang out with our second family, and delighted to see many of you here. It also turns out that Gabby has a case for us. So before he jumps in, I know Charmaine is also with her family, so I'll hand the mic to her to say hi, and then we'll jump right into the case, hang out, do our thing, and let you all get back to your families too.
Hi, everyone. Thanks for joining us. Happy Thanksgiving to those who celebrate it. I hope we can nerd out on medicine and then also spend some joyful time with our loved ones. And I'm so grateful to be with a community that I really care about and I've learned a lot from. So we couldn't say no to Thanksgiving VMR. Can't wait to get started.
Hi everyone, my name is Gabriel. I'm from Lima, Peru, and very excited to present this case with you. So I was thinking to call this case a vampire attack, and later you will understand why. So the chief complaint is acute onset of profound diarrhea.
All right. Okay, I can get us started. Wax poetically about diarrhea for a hot second, and then I'll have Robbie jump in. So I think when it comes to rapid onset of diarrhea, the most common cause is often gastroenteritis, foodborne illnesses type phenomena. So I think like the more acute, the more infectious etiologies are the ones to think about. The other things to think about are also like dietary issues, like, if you have lactose intolerance and you, just like me, love milk and cheese. Thankfully, I'm not lactose intolerant yet. It would be a very sad day. Then that can happen too. So I think a lot of the times with the onset, that's the couple of things to think about when it's really, really acute. And then I think we're at VMR, so patient's background would be informative. Someone who's immunocompromised, someone who is on medications like antibiotics or something, then we can expound our differential a bit more. RG, what else do you have?
I think you absolutely nailed it, my friend. It's amazing how when diarrhea is acute, the differential is very focused, as you said, and I have absolutely nothing to add. I think it's amazing to reflect on how powerful the patient's first words are. And if the patient's first words are diarrhea, often the center of gravity of the case is in fact diarrhea, but it's also not unheard of for the patient to start off with diarrhea and then describe a multi-system symptom complex. And if that's the case, then you should probably use the diarrhea as just the fact that when the body's unwell, the last thing it needs to do is to make sure that the stool is well, So I think the next key steps are, will the patient talk about anything else, or will it be remain on diarrhea? And so I pass the mic back to Gabrielle to round out the HPI, but I'm listening to that. And if that's not present and we're focused on the diarrhea, then I think it's infection, osmotic, or medication induced. All right, Gabrielle, back to you.
Awesome. So this aliquot is a little bit longer. So Valeria, if in any case you want me to stay a little low, just say so. So this is a 47 female patient that comes to the emergency department because of acute onset of profound watery diarrhea with no blood and no mucus. And the episode started after she woke up of a midazolam sedation for a cosmetic procedure called vampire facelift mask. So basically this procedure consists of extracting blood of your body and putting on a mask of a freshened plasma of it. So the episode started after that procedure, and in addition, she refers nausea, myalgias, and one day ago, the procedure, she had a nasal congestion and dry cough. And that started during her trip coming back to Lima in the aircraft. So during her trip, it was about 10 days, and she visited Madrid and the Switzerland. And one typical food she ate was oysters at the day of coming back, just before she got into the plane.
Oh, Gabrielle, I don't even know where to begin. I think it's become clear that diarrhea may not be the focus of the case, just with the multi-system complaints. And it's hard to, right now for me, it's hard to track a little bit the hypothesis, because it's difficult to know exactly the sequence of events. And I think rather than asking you to clarify it now, I would rather use this time as an opportunity to show everybody how hard it is in real life to make a diagnosis when you don't know what happened when clearly. And this is not an uncommon situation where relying on the patient to actually have a very good grasp of the history when they're feeling unwell is probably not a good safety mechanism to catch all error, because when it's hard for us to remember everything anyway, let alone when we're feeling unwell. So I'll just reflect briefly on where I think is going on, then pass the mic to Charmaine, because I don't think I have a great grasp and define it very clearly. I think what's become clear is a hypothesis that this may be related to the procedure that she received, either because of the actual procedure itself, or because of medication she received. And anytime you think about diarrhea specifically around the procedure, you wonder about the possibility of ischemic colitis, but also more morbidly, the possibility of anaphylaxis, which can have GI symptoms. I can't think of anything else immediately that I can overlap with the procedure and diarrhea. And then, she has travel related, so travel might come into the spectrum of infectious diarrhea, of which the incubation period here will be very, very low. And in oysters specifically, there's a variety of infections associated with oysters, ranging from hepatitis A, which would be way, way, way too acute. The incubation period for hepatitis A is weeks, but then also the possibility of Vibrio, which is associated with oyster exposure. So I don't know if you're playing on some V's here with Vibrio and vampires, but that's another thing to think about in a patient with diarrhea. But I'm sure that there are a lot of things that the dry cough, the myalgias, that are probably hard to incorporate, but I'll see what Charmaine has soaked up for this aliquot.
Just listening to you reason, my friend, one of my favorite things. Now I'm right there with you. I think the question still is like whether diarrhea is a center of gravity or not. If it's like more of an inflammatory type process, can like the myalgias, the more systemic systems be explained by that? Or is it diarrhea just a symptom of an underlying pathology? I really like to think about it like the same way like headache. If you're sick, you can get a headache, but headache alone can also be a pathology. As you, Robbie mentioned, with diarrhea as well. I think when, the HPI is a little vague and a little, like so many things can happen, there's travel, there's a procedure, there's so many things that could be, noise and versus signal. So I think like a background, a background information about her, a bit exam, and also like you just gotta have to rely a little bit more on your objective data to then come back and decide like, oh, which is noise, which is signal, and just kind of like go back and forth a little bit between those two. So I'm excited to hear more.
Awesome discussion, guys. So in the ED, hydration was started because she was dehydrated, and the initial labs showed a creatinine of 2.4 and a CBC with 15% of segmented neutrophils. So first, in the physical exam, she has a diffuse erythematous rash, and the patient was coming back so frequently to the bathroom because of the diarrheas were really severe. And so, and after that, it happened like 12 hours. The patient got really decompensated. The vitals were at temperature of 38 Celsius, pressure of 80 and 50, a heart rate of 24, and a saturation of oxygen of 97%. So she was treated with fluids and for shock. Also, she was treated with noradrenaline to maintain a mean arterial pressure more than 65. And also empiric antibiotic therapy was started with carbapenems. Do you want me to stop there? Or maybe I could give you some labs?
We can just maybe do a short pause here and then
Sure.
we'll go from there. Whoa, that is my reaction to this aliquot. So, I think when we started this journey, we were like, oh, if you have time, let's explain about diarrhea. Now we don't. So the patient, it's in shock. So when it comes to kind of like shock physiology and hypotension, that's the thing that I'm the most worried about now. And when it comes to the shock physiology, it's a treatment before a diagnosis. So kind of like thinking about as they did like fluids, labs, cultures, antibiotics, fluids, pressors to get the patient hemodynamically stable. So we have while like sending more labs. In terms of the shock physiology, there are a couple of buckets that we think about, distributive shock. It tends to be one of the more common things that we see, with both anaphylaxis, as Robbie mentioned, fitting there, sepsis, physiology fitting there as well. And then we think about like more cardiogenic as another bucket. We don't have any history of her having any reasons for that. And also kind of thinking about obstructive, like someone who has like traveled, for example, like PEs would be also on that in that category as well. So with her, I think we're just kind of most worried about a kind of distributive shock of physiology at that point and a reason for like SVR to be low. So in someone who's coming in with like diarrhea, these kind of more like inflammatory symptoms, I'm thinking about like infectious etiology with a diffuse rash as well. I think I really loved Robbie's thought of like including anaphylaxis, because with anaphylaxis, you can have bimodal reaction within like 24 to 72 hours. However, the second reaction tends to be a lot milder, so probably a little less likely here. So I think with her, I think broad spectrum antibiotic is a good call. Getting cultures is a great thought. Robbie, what else are you thinking here?
Yeah, I think this is very tricky because um, I think it's very tricky for many reasons, and I love the analysis that you have, and really have nothing to add to it apart from the stuff that would be in the back of my mind. But it's driven by the following observation, which I don't know if I really know, but I'm starting to come to believe it, which is that when patients have a systemic bacterial infection from routine organisms, the skin is rarely involved in a diffuse erythematous manner. Like when we see the diffuse erythema, we think, oh, maybe it's a viral infection or some esoteric infection for which we have schemas on the website like Rocky Mountain spotted fever and stuff that you wouldn't consider in this context necessarily. And so for me, when I think of an erythematous rash like this, the less common versions of these kind of common infections come to mind, and specifically the possibility of toxic shock syndrome, classically described with staph and strep, and can be post-surgical and usually takes a little bit of organism. to cause devastation. So I have nothing to add to our list of, hey, you know, could this be a severe infection from food? Could this be a severe infection related to her surgery, possibly with phenotype of a toxic shock syndrome? Could it be anaphylaxis? And I love the caveat of the second phase of anaphylaxis being less severe. I actually forgotten about that. And then other things that can cause a diffuse rash that can leave somebody very ill are heavy metal toxicities, which we don't have a flavor of here.
Yeah.
So yeah, I'll pass the mic to Gabrielle to give us, but this in real life, this would be a very, very tricky
Yeah.
case to get to the bottom of, and one that you'd have a lot of people.
Yeah, I love that, Robbie. That also made me think about like, oh, the skin, and also like thinking about the mucosal services, thinking about, you know, SGN, and then with someone like getting procedure, like if they've got a drug that they've never seen before. So thinking about like our drug spectrum reaction, a lot of them take weeks to show up. But thinking about the rash, that also reminded me of like thinking about drugs. Thanks, RG.
No, you know, I think one thing that you should mention right now is you should probably bring near the top. I didn't think of it at all. It's not uncommon that patients get acute generalized exanthematous pustulosis or AGEP after antibiotics in a procedure. So I think that's a really good thought. And the one thing about that that's probably actionable is patients usually have tiny follicles that you tiny pustules that I've missed many times. You have to get like really close to see them. So I think drug is really good thought here. And the one drug that commonly occurs right after is AGEP. Really, really good thought.
Awesome, guys. So for initial labs, the leukocytes were 18.3 with a differential of neutrophils of 65, lymphocytes 9%, eosinophils 0%, and segmented 13%. The hemoglobin was 9.4. The platelets, at first, they were 120, but after that 12 hours that the patient got decompensated, the platelets were 56. The PT time was 52, which was elevated. Glucose was 55, which was low. Urea was 102, which was high. Creatinine 4.4, and the creatinine also elevated at first because it was 2.4 and then became 4.4. Iodinized calcium 0.95, low. Magnesium normal. Bicarbonate 11.3, low. AST 99, which was high, and ALT 38, normal. LDH was 524, which was high, and PCR, the C-reactive protein. In Spanish, we say proteína C reactivante, then it's PCR. It is 154.8, which was super, super high. And the procalcitonin was 100, also super high. So in the clinical evolution, the blood cultures were all negative. All the four cultures didn't grow anything, and also a FIMA rate of feces sample was shown. And this exam identified a lot of organisms and all became negative. So after that, a final diagnosis was done.
It's always amazing. I think some of the best cases we'd ever discuss are like, all these tests were negative, and then we got a final diagnosis. And you're like, oh my gosh, how am I going to get an answer? And the truth is, I don't think you know, it's not uncommon in VMR where you make progress logically and sequentially through testing, and you're like, oh, it could only be these three things. Let's send 1 or 2 tests and we'll be able to tell it. This is not that case for me. I have no idea what the diagnosis is confidently. And I think I'll just share one schema and then hand the mic to Charmaine to see what she thinks. And that is, oh, sorry, I accidentally closed it. Give me 1 second, then I think it's worth it. I hope at least. Okay. So this is, I think, the center of the analysis for me is centered around this conversation, which is the patient is prominently inflamed and the center of gravity of disease appears to be in some part of the skin. That may be an overcall. We have a lot of other manifestations with diarrhea and the liver and the lab abnormalities that are happening, which I'll pass to Charmaine to reflect on. And as she said, drugs, drugs, drugs. They really center on this, and I think age-up, as we talked about, would be the most fit for the time course. So would anticholinergic toxicity, but I don't think we have reason to suspect that. There's a variety of infections, and I think toxic shock is worth considering because it tends to be culture negative. It's really not so much the organism that does it, but the toxin it releases. Cancers here, there are some, but they're way too abrupt. And similarly, some autoimmune diseases appear to be way too abrupt, and there are some other things to entertain. And so I think the question is, are you drug or infectious? And I actually don't know how helpful the procalcitonin is in locking in infection. And I think that has to be married with the fact that drugs are probably more common. So I'll pass the mic to Charmaine to see where she's at and if the labs help at all. But I have to confess, I think I'd be very thankful for the VMR family's help to the chat and Charmaine's input as well.
Yeah, no, I'm right there with you. I think what I'm trying to do, I don't know now what the answer is going to be, but it's as Robbie said, like try to figure out what information, like going back to the HBI, is there any help there? Is there any help with the lab, like the thrombocytopenia? I'm like trying to run through the cases of drug toxicity that I've seen that has like a thrombocytopenia in them. Not that often. And then the other thing is like the diarrhea itself. Just given the abrupt nature of the diarrhea, I think it like makes a good story for like kind of like toxic shock from like staph type of species, something like that. So I'm just by experience and no logic at all, I'm favoring infection. But I think as you mentioned, I think like with the procedure, drugs are right up there. So kind of making getting a maybe better son of what she was like exposed to previously. I think the time frame of rather it being acute, although she had that, it was like 10 days ago that she had the procedure. Yeah, I'm still slightly favoring infection. I think with the age up, I think is a good thought. Like the other ones, like especially like dress, at least like it takes up to 6 weeks for it to show up. But I don't know. My favorite 3 words in English. Actually, JK, my second favorite. Y is my first favorite. Anyways, any other thoughts, Robbie?
No, I think if you're playing the clinical reasoning game of like these cases, toxic shock is, I think, the abrupt watery diarrhea, erythematous rash, and thrombocytopenia would be something that a shrewd presenter like Gabrielle would be trying to sneak you. But I think in real life, it's probably more complicated than that.
Totally.
Practically, if you're thinking toxic shock, this is very hard because you have to go on the hunt to feel like, is there a retained foreign body or where is it coming from? And so I think even though it may not be toxic shock, what you should probably do is look at the skin very closely to see, is there a nidus for infection that's very small, including a foreign body from the procedure, or are there pustules that you didn't otherwise appreciate? So this is the time where the exam might be the clincher, which is not common in a mystery case. But yeah, I'm right there with you. We'll see what Gabrielle has in store.
Gabrielle, you never disappoint, my friend.
Yeah, so the final diagnosis was toxic shock syndrome, and actually, when reading, when discussing this case with my professor, I was reading about a little bit of toxic shock syndrome and realized that it's actually a diagnosis of exclusion, and the criteria is a clinical criteria and lab criteria, and the clinical criteria is the patient had fever, hypotension. Also, the skin compromise, that diffuse erythematous rash was actually erythroderma, and also the multisystem involvement, including, so in this case, the patient has hematologic involvement because the platelets were really, really low. Also gastrointestinal involvement because of the watery diarrhea, a muscular involvement, the patient has fibromyalgia, also renal involvement. And in the lab criteria, you have to exclude other diagnoses such as Rocky Mountain spotted fever or measles, leptospirosis, and also do cultures in case a Staphylococcus aureus grows. But using that criteria, the final diagnosis was a probable case of a toxic shock syndrome because we didn't see the desquamation in this patient. So what I learned, especially about this case, is having this diagnosis as a never means one, and especially this can present as just acute onset of watery diarrhea. And in these cases was actually really hard to how to anchor our differential because there was a lot of things going on: the trip, the austere, the nasal congestion before the trip, the watery diarrhea, the cosmetic procedure. So our hypothesis is that when doing that procedure, it basically consists as invasive procedure with microneedles on your face. So the face barrier was compromised, and it was like aside for the Staphylococcus aureus to get into the body.
Wow. That was such a fantastic case. And I just like feel so bad for this lady who it's just like nothing we do is benign, and having a cosmetic surgery that turned out to have a severe complications. And Gabrielle, I'm just so glad the patient was in safe hands like yours. RG, any last thoughts before we hand the mic to the amazing Andrea?
No, this is one of my favorite VMR cases, and I think you learn so much from these cases. Period. But I think for those of you who are thinking about presenting a case, you can see how I think you should recognize that it really is an expert presenting it today. It's probably intimidating to watch Gabriel do his thing because he leaves the story pure. There's everything about oysters and Madrid and a lot of like authentic real life distractors. So if you're thinking about presenting a case, I think the biggest takeaway is watch Gabriel very closely. And I think the key is just tell the story how it actually happened. It's not more complicated than that. And so I hope you use today to inspire you to learn more about toxic shock, but also about the simplicity of doing a case and laying out such a great story. So thank you, Gabriel, for doing that. All right, Vale, the mic is yours. Andrea, excuse me, sorry. The mic is yours.
Hi. So we started with a case of rapid onset of diarrhea. So we talk about gastroenteritis, infectious etiologies because they tend to be more acute, or something that carry like lactose. And then we talk about vampire face lifts. That is a cosmetic procedure in which your platelets are injected under your skin along with hyaluronic acid filler. That's what this patient had. We recognize that it's difficult to get a good story, especially when you are ill. And when you, in this case, that you have diarrhea after a procedure, you have to think about ischemic colitis or anaphylaxis. And the patient also ate oysters that make us think about Vibrio and hepatitis A, but it takes weeks to develop. In the differential diagnosis, we have anaphylaxis, sepsis, cardiogenic cause, and obstructive cause like a pulmonary embolism. Normally, the systemic bacterial infections involve the skin very rarely. So we were thinking about this. And this erythematous rash, toxic shock syndrome, could be post-surgery or heavy metal toxicity. Then I learned about acute generalized eczematosis pustulosis, or AGEP. That is a pustular drug eruption characterized by superficial pustules. It's a severe cutaneous adverse reaction to a prescribed drugs, and it's difficult to examine because they are very tiny. It can be missed easily. Then we have that this patient have inflammation, and the center of gravity was the skin. So we talk about drug or an infection. Toxic shock syndrome has negative cultures, and it's characterized by fever, hypotension, rash, and multisystemic involvement. and it's a diagnosis of exclusions. It can present with thrombocytopenia and look for foreign external bodies in the procedure. Everybody has heard about the tampon. That's the one I always think when I hear about this, but in this case, it was due to an infection. Thank you very much.
Boom. Thank you so much, Andrea. Thank you, Gabrielle, for presenting Valley for scribing. And thank you all for joining us. This was so fun. I couldn't have asked for a better start to Thanksgiving than this. Have a wonderful rest of your day, wherever you are, and we'll see you next time.
Thank you,
Bye.
guys. Bye.